All right, welcome everyone back from coffee. So we have we're really lucky today to have a number of talks and experts speaking on cardiac amyloidosis, and we've touched upon it already. So my brief today was to talk about some of the challenges, the chronic challenges and the emerging challenges. And I suppose as I was thinking about it this morning, I was like, oh, is this going to seem really negative? Because I think the goal of today is a really positive day, just like it was 3 years ago. Really, really good positive spirit. And as I was thinking about it, the challenges are arising almost out of positivity, because as we're diagnosing more and more people, more and more early, but we can still go earlier, and as we have all of these treatments, we're obviously building up to a crescendo of need and a crescendo of resource need, human resources, personnel, logistics. And so, there's a lot of opportunity and positivity in the challenges, but there nonetheless are challenges. So we're going to talk about those today. These are my disclosures. So as I lay out the challenges, there are 3 distinct categories that currently practicing in Dublin and being a referral centre for cardiac amyloid that we see. Diagnosis remains, again, as you've heard, the biggest group of challenges that we face and what we really need to focus on the most. There still remain a lot of awareness gaps. We're a very sort of not biased room, interested room, but outside of this room, outside of GPs and hospitals in Donegal, in Dublin, in Derry, and certain areas, there are still a lot of awareness gaps. Amyloid is the great mimicker. I'm going to talk about that in more detail in a minute. We're still missing opportunities for screening in high-risk groups. We still have inadequate testing both to the non-invasive and the invasive pathways. We have limited access to genetic testing, although that's getting better. We have no access in the Republic to tissue typing. We have wonderful service from our Royal Free colleagues, but that is something that we would like to ultimately see in terms of reducing diagnostic delays, particularly as it relates to AL amyloid. We have very unique both opportunities and challenges, but related to, of course, our variant ATTR population. We also have challenges in relation to treatment. Again, we have to preface, as we've already heard, to have challenges in treatment, that's a good thing, because we actually, of course, have treatments. But there's still a mismatch between the pace at which the advances in treatments are coming and the access to therapies. So that's what we need to work on, and that's what we're so engaged and enthusiastic about. We ourselves, you're probably going to hear a little bit about it from me, but also from Professor Murphy speaking later. We have prolonged national reimbursement procedures that can place some barriers. We have financial burdens and toxicities associated with the therapies, both on an individual, a hospital, and of course, a state and country level. And there's increasing complexity. Great to have all of these treatments, but it does present a lot of questions about questions that we never had before, questions that we didn't even have to think about before from ourselves in terms of prescribing. We have a lot of challenges in terms of funding and resource management. We still have no funded model of care. If you told me in May 2022 that when I was saying this exact slide or thing, that we still wouldn't have it in June 2025, I would have said, no, that's too negative. But maybe we've made some little progress. Maybe there are some glimmers, but we've a long way to go. And of course, that has a knock-on effect. And also, we need to think about registries and data and all of these treatments available. We need to understand them and learn more, as I was saying, about what best treatment regimens there are. Individualized therapies, perhaps one size doesn't fit all, and that's, I think, where the field needs to move towards as well. I mentioned that amyloid will focus on diagnostic challenges, several of them for the next couple of slides. So amyloid is the great mimicker, and what I've made my peace with to a certain extent is I think there will always be a difficulty in diagnosing cardiac amyloidosis to a certain extent. And I think that's not being negative, that's being pragmatic. And once we recognize something and are aware of it, I think then we can focus in resources. And that's because, and a lot of this is probably referencing wild-type cardiac amyloid, but also our AL patients and some of our later presenting variant patients. The initial manifestations are often mimicking conditions that our day-to-day cardiologists and general medical physicians and GPs and nurses are seeing day-to-day in their clinics anyway in patients who don't have amyloid. So there's a huge burden of heart failure, preserved ejection fraction heart failure, stiff heart failure as we get older, associated with diabetes, obesity, hypertension, coronary artery disease. And a lot of that is those conditions, but some of it is amyloid. So it's difficult to think about it in a busy clinic. So we need to recognize that and maybe not just fight against it. Atrial fibrillation, very common in amyloid, very common in very many clinics across all of our specialties. We're seeing many patients with an irregular heartbeat or AFib. Conduction system disease, people who have pacemakers, very common to have pacemakers, not because of amyloid, but just because your conduction system is aging or you have other conditions. Similarly, angina, unexplained thickened heart disease or left ventricular hypertrophy, or having hypertension, which causes LVH, but maybe there's amyloid too, maybe there isn't. So these are often very difficult in a day-to-day clinic, so I think we need to recognise that, particularly in non-specialists. That means being pragmatic. Okay, this could happen, it is a great mimicker, what do we do? Well, we need to screen and target our screening in these prevalent conditions, particularly in patients who are presenting perhaps with the heart failure preserved ejection fraction and one other thing, like carpal tunnel syndrome, like lumbar spinal stenosis, like family history, all of these things that can come together, unexplained unexplained heart thickening in the presence of heart failure symptoms. So we really need to think about it, but maybe if we target screening, even without thinking about it in these patients, and this was a nice study that showed quite a significant prevalence, up to 10% in conditions like heart failure of preserved ejection fraction, aortic stenosis, which is a thickened heart valve condition, very common also as we age, and often we're finding patients who are undergoing workup for treatment for aortic stenosis because there's a specific treatment who end up having amyloid as well. TTR particularly. Hypertrophic cardiomyopathy is a common-ish condition, genetically inherited, but again, this can often be diagnosed later in life, and we're finding more and more that maybe some of these patients diagnosed with hypertrophic cardiomyopathy or thickened heart cardiomyopathy later in life are actually amyloid. So it's a case of really kind of thinking about it. Myself and our colleagues in the matter, Dr. Giblin and our team, we came together and kind of looked at our undifferentiated population. So not people that we'd already suspected cardiac amyloid in or TTR or AL amyloid in, but our general population of patients attending our heart failure clinics who did not have a diagnosis or other red flag of amyloid. And we looked to see, well, what is the prevalence in this undifferentiated population? And we found 8%, so almost 1 in 10 patients that had sort of passed through our general screening and our hats at the time, but actually this was wild type amyloid. This was more likely in patients who were older, who were male, who had thicker walls in their heart, and so had some abnormal blood tests. So, however, if we just do that, that's also not, it's not going to be good enough ultimately because if we wait for cardiac manifestations, then we already have established disease. And my day-to-day dealing with heart failure patients, there's a lot we can do, as we've heard from Kathy, to treat heart failure, but really by the time stage C heart failure, and that is when you need that loop diuretic, that furosemide, that Buronex every day. When you need that every day, or when we're monitoring that blood test, that BNP blood test, when that's up, that's really denoting a certain prognosis that's independent of all these wonderful treatments that we have. So really we want to diagnose people before we get that stage C heart failure, because regardless, there's going to be some consequences just from having that heart failure syndrome. So this is where, and again, we've heard about this, tying it together, these extra cardiac manifestations, the connective tissue, the neuropathy, are these potent opportunities for earlier screening in both the hereditary and the wild types. Carpal tunnel syndrome is the obvious low-hanging fruit. I actually have 2 orthopedic surgeons now who are staining median nerves in certain populations, men over 50 particularly, but again, we need to widen that. And we've had some positive median nerves come back for amyloid, and I think that's probably where the field needs to go. And as we said, and as we've heard, potentially treating these patients. As of now, we just follow them up, do the DPD scans, but I think it's definitely a potent area in the future. This was a nice study that in a total 100 patients, nearly 100 patients undergoing carpal tunnel release, 10 of them, so 1 in 10, stained amyloid. There was various types, mostly TTR in that biopsy. More likely if they got bilateral, like we've heard, if they're older age, and if they also have increased wall thickness. Another sort of opportunity/challenges, again, we've heard of some of these in terms of diagnosis that we see with our cardiac amyloidosis, is of course the prevalence of our variant ATTR population. This was a study, I used to call it contemporary, that myself and Professor Murphy, Dr. Giblin and team performed a couple of years ago, where we looked at our cohort at the time and we sought to determine, well, what mix, as we've heard, of cardiomyopathy and neuropathy the patients were presenting with. And as I look at it now, it's incredibly depressing. Most patients, actually nearly 2/3, already had heart failure by the time of diagnosis. This is a variant population. 40% atrial arrhythmias, over 70% had some form of neuropathy. Obviously, carpal tunnel syndrome was quite prevalent, but also large fibre and autonomic dysfunction. So our hope is when we redo this in a few years' time, that will be completely different. And it is already different. We're already, through our screening programs and through our therapies, treating and finding patients much earlier. We have unique variant diagnostic challenges. These are some of the issues that Sinead and I will be talking about on our monthly or so MDTs. We've talked about the carriers, the asymptomatic carriers, that within that 10 years of PDAO in the family member, okay, we screen them, but when do we rescreen? We have to think of resources in our, very resource-strapped clinics. We have limited access. We have some, but limited access to gene counselling. What about our patients with grade 1 uptake? They've no neuropathy. They have a variant. How do we manage those? Are we subjecting them to heart biopsies? We're going to, hopefully be maybe doing neurofilaments and increased prevalence of skin biopsies, which we're already doing. But again, that's a diagnostic challenge to think about. What about those who've neuropathy without other cause in a gene carrier who's a negative DPD? Again, how can we get them on treatment? As we've heard from Mary, potentially going down the route of skin biopsies, which we're doing. But perhaps there are other diagnostic tests that we'll have in the future. An interesting one that we're seeing more and more is we're doing a lot of genetic panels in general for heart disease. So our traditional stretched heart disease, dilated cardiomyopathies, other hypertrophic cardiomyopathies, we're doing them in younger patients. And what we're seeing is maybe these patients coming back, they don't have a typical TTR look to their heart or phenotype to their heart disease, but they're testing positive for the TTR variants. And we have a couple of these with the 122, 142. Isoleucine mutations, which we know typically doesn't present till the 6th decade. Is that a 2-hit? Is it involved somehow? I think there's a lot of interesting things there. In terms of, finally, to finish up on diagnostic challenges, you could probably do a whole slide on this. You might hear about this from other colleagues in terms of lack of access to specific testing. Still not protocolized. Of course, it isn't without a properly funded model of care. We do the best we can. We are lucky in the matter to have and to be able to provide, I think, for a lot of the country, DPD scanning with SPECT-CT, but there are large areas of the country who don't have access to that. There are other areas that do have bone scintigraphy alone, but without the SPECT-CT, there's, the caution in terms of accuracy in some of those cases. But the main problem in those centres is that the amyloid cases, bone scans are done frequently for oncology reasons, prostate cancer, other types of cancer screening, and so patients are often waiting and competing with those oncology wait lists in those centres. Unfortunately, in the Republic, we really don't have the access to cardiac MRI. I hate to say this, that we would like to have. We have maybe access in the public system, but it's longer wait lists. We can maybe get purchase orders for private tests, but again, long wait lists and just not the level, and would love to have greater access to this in terms of monitoring response to therapies and in helping inform future treatment decisions. But as of yet, that is not quite where we're at. And we are the National Transplant Centre in the Mater, so we very frequently perform cardiac biopsy, but it is very limited capability outside of that National Transplant Centre. And some patients will still need invasive tissue, often a heart biopsy, to make this diagnosis. And not here is the genetic testing and the tissue typing. But again, to bring it back to some positive, obviously a whole new abundant era of access to disease-modifying therapies, which you'll hear more about. Our silencers and our stabilisers, which we've had, but now we've newer agents within those categories, and we have our ongoing clinical trials with gene editing agents and with our antibody-mediated removal of fibrils or depleters, which is also very exciting. So hugely exciting treatment landscape. With that, as I've already said, it does bring challenges. Financial cost, we have to talk about it, we have to mention it, and hopefully it's something that with our industry partners, as we work on this, as there's more studies, as there's more access, that's something that will improve. As prescribers, as I said, we're going to be faced with these questions, which is great to have them, but it's going to involve a lot of shared decision making, a lot of multidisciplinary teams, and probably future studies to inform, well, which one do I start first? Can we do combination therapy, or should we do it in this group of people? How do we define worsening disease? That's, I think, where the field needs to go next. Who are those people? There's probably, we know there's going to be people who are going to do very well on that initial therapy, but who are those patients that are not doing well on that initial therapy? And how, can we define that, and can we move on to an upgraded or an alternative treatment regimen, or a second-line treatment, or a third-line treatment? And I think that's stuff for us to talk about and work on as a field. It is wonderful in Ireland that we have access to 3 such disease-modifying therapies via the Managed Medicines programme. You'll hear a little bit more about this from Sinead. We have tafamidis available, the stabiliser, as you've heard. We have patisiran, which is replaced patisiran, our gene silencer, and we have eplontersen as well. So wonderful to have them. There are, as with many, I suppose, programs, and that is simply the case. There are some challenges. It's a time-consuming application process, difficult to do, on a general clinical stream, but it has to be done. The biggest challenge is probably prolonged length of time for approving reimbursement of these European Medicines Agency approved therapies and FDA approved therapies, but just even though they're approved, getting them through our reimbursement processes, and we really need to work on reducing that time. Strict eligibility criteria is obviously a good thing. We do need to have certain absolute criteria to meet these. Well, I'm not sure about absolute, but we need to have certain criteria to meet for these therapies. But there can be nuances and things on a subspecialist or a multidisciplinary level that perhaps can be difficult with very, very tight criteria. And lack of access to approved therapies for some clinical trial patients, but that's something that we're working on. So moving on finally to resource challenges. Again, as I've already said, I didn't keep you in suspense. The model of care is still not formally funded. This was something that we worked on in 2020, Professor Murphy and I, and obviously Dr. Mark Coyne, who chaired it. That called for a lot of things, guidelines about the patient journey, establishment of a national registry. We've had a lot of engagement. We've had a lot of meetings. Sinead and myself, Rosaline and the team have done wonderful work in terms of questions in our parliament. And perhaps we're starting to get some traction, but again, it's probably something that, like anything in medicine, it's written 5 years ago, that we also need to look at and perhaps revise and work on further. So solutions, enough about challenges. Call to action. I think we really need to work on a national amyloidosis strategy. We need to fund either the 2020 model of care or the 2025 version of it. We need a national registry and screening programme for the ALA-80s variant, and that's for sure. We probably need to look at our regional centres outside of Dublin, especially for diagnosing wild type, for diagnosing and treating AL, and really centres that then link into that expert network, and I'll show you a proposed model. We need to continue education, enhance awareness, continue liaising with our wonderful patient groups, and really increasing international collaboration, ongoing collaboration with Professor Gilmore and colleagues, and also outside of that in terms of research and education. And also the focus on a multidisciplinary. I think we've heard a lot about that need to focus on psychological care, frailty care, even palliative care, but just all of those other services. I think at some point it needs to move beyond, hopefully, diagnosis, because diagnosis will be more set in stone, access to therapies more protocoled and easier. And then we can actually look at improving things like quality of life. So just a couple of suggested things. This is probably a version of a model that we're currently doing between Sinead Murphy and I, our colleagues in the Matter, together with some other Dublin centres and regional units. And I think this is something that is more or less proposed in the model of care, is having our expert network centres, probably trying to, mimicking the NAC, but obviously liaising with the NAC as well. But that centre being the core for our complex cases and diagnostics, our variant patients and screening and asymptomatic carriers, provision and ability to do clinical trials, which we're currently involved in a few, obviously potential transplant for AL and other potential advanced therapies. And they're fed into, or we feed into, or are fed into by the regional units, which can focus on the diagnostics, that earlier access to diagnosis and guideline-directed therapies, particularly for wild type and AL, and of course liaison with that expert network if worsening disease. And probably most important is those outside circles, like you've heard from Kathy, those community heart failure and symptom hubs. Our community hubs are our primary care hubs, which are really important, and we've got a particularly good network between ourselves and Kathy, which is a really, I think, a gold standard for how to sort of liaise in between the spokes. it's a lovely slide from my colleague, Dr. Giblin, but really honing in on the need to focus on that multidisciplinary patient-centred care. I think you can do that in the Expert Network Centre, but also in our regional units and in our heart failure clinics. Research is essential. I think particularly patient-centred research. This is just one project. I got the opportunity to work with an Australian fellow over the past year through a grant. I think I'm supposed to mentor her, but she probably mentored me more. We got the opportunity to go over to the Royal Free and have a great day over there, but we've just developed this amyloid patient experience survey. Thank you to all of you who have filled it out. If you haven't, there's the link, but I also have the QR code, so you can come up to me afterwards to get it. So a plug there. I think we've over 250 responses so far, but 68 items look scary. It takes about 10 to 15 minutes, but really, and Professor Murphy is involved as well, and just looking at how, in those of you who, and others who have amyloid diagnosis, how you got there, how long it took to get the diagnosis, what was your journey, with obviously the goal of improving that, reducing those diagnostic times in future. So I'll end there just to say there's a lot of positivity which is highlighted, especially here today. This was all of us. I don't think we've aged too much when we look at this. And I want to say a massive thank you to Rosaline and the team. I mean, this is just, it's as we all say, it's heartwarming, pardon the pun, to be here. And there's a vacancy in a top job in the HSE in the Republic of Ireland coming up. So I think any of you could be going for that with much success. So anyway, thanks so much. Great to be here.